Good morning, everybody. We're going to talk some about vascular disorders. So this is chapter 35 in your book, so that's page 1057. So when we're talking about vascular disorders, of course, those are disorders of the arterial, venous, and lymphatic systems. So, this chapter is mostly about peripheral arterial disease, but there are some lymphedema and things like that we are going to discuss a little bit about. So when we are talking about peripheral arterial disease, now there's different forms of that. So occlusive, and aneurysm, and then vasospastic disorders. Those are the three main breakdowns that we're going to talk about. So most of the time when we're talking about peripheral venous disease, we're talking about the legs, right? That's typically, but patients can have issues with their upper extremities as well. But we're pretty much going to be talking about the lower extremities. So we're going to be talking about venous insufficiency and thrombosis as well as we go through this. Now lymphedema. As you guys know, that is just an abnormal fluid collection in the lymph system. A lot of times when we think of lymphedema, we think of our patients with breast cancer and things like that, but there are several different causes of lymphedema. And like I said, we're not going to talk much about that, but we will talk a little bit about it. So when we talk about the arterial system, and I did put a diagram in your PowerPoint. Now, what is the function of the arterial system? We've got to get oxygen and we've got to get nutrients to all of our tissues, right? Or our body doesn't work very well. So our body, we receive the oxygen and nutrients through the blood, and then the blood picks up the waste products, and that is how it works, as you guys know. Also, when we talk about the arterial system, it also regulates our temperature, so that's another thing to keep in mind. Of course, when we think of thermoregulation, that's the beauty of hair, and if we don't have a lot of hair, we need to wear a hat. Try to keep that heat in, just to keep the body nice and toasty. Now, the venous system. What it does is it just circulates, it picks up the circulation, and it gets that blood back to the right side of the heart. Remember, we've got the inferior and the superior vena cava. We'll pick that up, put it to the right side of the heart, and so it's getting it back to the lungs so that it can get more oxygen, so that the other side of the heart can pump it out to the body. So it's just a pump system. And used to everybody thought of it as a one pump system, but these days we've kind of changed, and it's a two pump system. We talk about the left side of the heart versus the right side of the heart and what they do. So now it's thought of as a two pump system. So the venous system also has this lovely function. As you know, the arterial system is under it's a higher pressure system, and the venous system is a low pressure system. So the venous system can accommodate these big shifts in blood volume, and it doesn't change the pressure. So that's another thing to think about, is that there is a huge capacity for the venous system to hold extra blood in there. Now, I also wanted to go over a little A&P review, and the thing is that I know that you guys hate it when I read to you, so you will see most of this in the PowerPoint, but I know that some of you like to hear it. So if you like to hear it, great. I'll try to keep it. I'll just keep it short and sweet. And if not, if you like to read it, then just skip through here. Now, we have our system of blood vessels that's getting this oxygenated blood and picking up the deoxygenated blood. And so, we've got our arteries, veins, capillaries, lymphatics. We've got our layers to the artery. We've got our tunica intima, which is the inner lining. It's a smooth surface, hopefully, in which the blood can flow. We don't like the turbulent blood flow, do we? What do we hear when there's turbulent blood flow through a vessel? You guys know this already. So yes, we like that nice smooth flow of blood. The tunica media, that's the middle layer. That's the elastic level that's where the strength comes from. The elasticity comes from the tunica media. The tunica adventitia is the connective tissue that it anchors the vessel and it surrounds it. So it's really important. While you don't think much about the different layers, now that we know more about um, how the cardiovascular system works, we've learned how important that these three layers are. I mean, we knew what they were, but now that we've figured out a little bit more about plaque and things like that, we've learned a little bit more about how things work. So it's really important to know those different layers, because you will see that. I mean, not for testing purposes per se, but you will see that later, and you will be thinking about it and pondering, oh, hey, this is how a plaque ruptures, or things like that. So it's really important to know your anatomy, so that you know exactly what's going on. So let's talk about the tunica intima a little bit. So now, remember, we talked about how it is it's a really thin layer. Now, what happens is, like I said, it's continuous through the vascular system, but it thins down to just a single layer in the capillaries, so that we can get that exchange. That barrier is there for exchange, and it's got to be really thin for things to cross it. So the layer is thinner in the capillary beds than it is just through the rest of the vessel. Now, the tunica media, like I said, it's smooth muscles, and it's collagen, and it's elastin is the components of that. So the arterial system, as you guys know, it's a high pressure system. So and as you guys also know, it really helps regulate the blood pressure. So this smooth muscle layer is really important, because it helps dilate and constrict the vessel, so that blood volume can be adjusted. Remember that that's a big change in our blood pressure, comes from the differences in how these vessels contract and relax. So as we talk about atherosclerosis and things like that, it's really important to think about how the vessels really work, because once a vessel has an issue like atherosclerosis or things like that, it can't constrict and it can't dilate like it normally did. So that area of the vessel really is not contributing much. So it can't, it really can't regulate our pressures and things. So I really want you guys to think about how important it is to try to keep our blood pressure in check, and how important it is to keep our cholesterol levels and all these plaque formations out of our vessels, so that our circulatory system can continue to work at the appropriate level like it's supposed to. I really think that's probably all I'm going to talk about on this, and I did put a diagram in your PowerPoint so that you could see the different layers, just so you get a better visual of that. Now, veins, they're thin-walled, or more thin-walled than an artery, because there's not that pressure. It doesn't take that pressure and that trauma and all the beating that an artery does. So the veins are more thin-walled. Now, as you guys know, they're picking up the cellular waste, they're picking up the CO2, they're taking it back to the lungs, trying to get some oxygen put back in that blood, so it can go back and do it all over again, the lovely cycle. Now, our veins have valves to prevent backflow, right? So, they're really tubes that collapse when they're not filled with blood. Now, veins do have the same three layers as the arteries, but they don't contract, right? They don't have the contraction capability as well, because they don't need it, as an artery does. So the tunica media isn't as thick in a vein. Now, what happens is, as we move, and breathe, as we're moving, our skeletal muscles are contracting. And so that's helping move the blood along. And then also think about, we have our intrathoracic pressure and intra-abdominal pressure. Those things also help blood moving. Now, if we're not moving, which, like we're in bed at night, if we're bedridden, if we're standing for long periods of time, if we're laying for long periods of time, things like that, then the blood can pool, right? And so, you know, you see these patients that'll stand up really quick and they feel really dizzy, like they're going to faint. You know, that's just can be some of that venous pooling. So, you know, just always think about those things. So, well, really, I guess the best thing that I can say is I tell patients, especially if they've got cardiovascular issues, you know, if they're in a car, if they're riding for long periods of time, hey, I want you to get up and move around. You know, most people think that you're just telling them that because you don't want a clot to form, and that is true. But, you know, there are other issues that we need that blood circulating for because we don't like the venous pooling. So, you know, I will have patients get up and walk every hour or two, you know, just stand up and move around, shake their legs around. If they're in bed, you know, you can help them, you know, get that circulation going a little bit as well. Now, veins are also called capitance vessels because about 60% of blood volume is contained within a vein. So see, that's a huge percentage, and that's the importance of getting this blood moving. Now, the lymph, I'm really not going to talk about that a whole lot. You know, lymph is a clear fluid. It's water, protein, minerals, and white blood cells, and it bathes the tissues. So what the lymphatic system does is it absorbs that excess fluid, you know, that interstitial fluid, and puts it back in the bloodstream so that it can be, you know, filtered out and get out of the body. Also, it absorbs fatty acids and fats from the digestive system. So, and then, of course, you guys know that it works with the immune system, and it gets white blood cells to and from lymph nodes and into bones. So, I mean, the lymphatic system is really an important system, and for so many years, it really hasn't gotten much credit. So, I went ahead and put in, you know, some of these functions so that you guys would think about the lymph system a little bit more in its function. Now, you know, some of the vascular disorders we're going to talk about are hypertension, peripheral arterial disease, Raynaud's. We're not going to talk as much about some of these as we are others, but you know, I wanted to put them in here because they are in your book and they are things that you will see. So anyway, that's why they're in there. Like thoracic outlet syndrome, that's not something that you see every day. Now, renovascular disease is one that you're going to see because as you guys know, anytime we have issues with blood pressure or diabetes or things like that, we've got to worry about our target organ damage. And so the kidneys are one of those that we really need to watch. Kidney disease starts you know, very early in the game. We can start looking at people's protein in the urine and things like that so that we can keep an eye on our renal function. And so renovascular disease is very important in the game because we really would like to keep our kidneys functioning as long as possible. You know, I personally don't want to have dialysis ever. So renovascular disease, people are, you know, starting to plug that more and start looking at you know, kidney function early on more than they used to. We're going to talk a little bit about aortic aneurysm and dissection and varicose veins and the venous thromboembolisms as well. Now, hypertension is a huge risk factor for everything in the cardiovascular system. But since we're talking about the peripheral vascular disorders, you know, we're going to talk about hypertension quite a lot. And of course, as you see, you know, I've seen people go in and take blood pressures on patients and just go, oh, that's close enough. But really, you know, while the machines, some work better than others, you know, it's not as good as a manual blood pressure. So there's my soapbox for the day. I think that if you know, as you progress and, you know, you guys are going to be RNs, it's very important that you guys make sure that your CNAs or techs or whatever you like to call them, are working really closely with you. And you need to make sure, because, you know, that lies on your head, that they know how to take a correct blood pressure. So, you know, I just want you guys to think about that, because I don't think a lot of people think about the seriousness of it. So, a good blood pressure is so key to everything. So, I'm off my soapbox now. So I'm not really going to go into detail a whole lot about the 4 stages of hypertension, because you guys can look at those and well, you guys can look at those, so we're not going to talk about it a whole lot. But now, pretty much, there's 3 mechanisms that help control our blood pressure. So we've got our baroreceptors, which, you know, we've got our pressure receptors. We've got our autonomic nervous system, which is our fight or flight. We can't control it. I also put on there the rest and digest, because I've always thought that that's kind of funny. And then our intrinsic hormones, which is our renin, aldosterone, angiotensin system, you know, our ROS system. So now our systolic pressures, I put definitions in here just in case you guys didn't remember exactly. You know, our systolic blood pressure is where it's the contraction and the emptying, and then the diastolic pressure, you know, diastole is the relaxation and filling. So I went ahead and put those in there just for a refresher for you guys. Now, pulse pressure is the difference between the systolic and the diastolic pressures. Now, our blood pressure is a product of our cardiac output, and our cardiac output is simply the amount of blood that's pumped by the heart each minute. And of course, you know, it varies between people, you know, males and females and your different sizes, but so I'm not really going to get into that, but anyway, just so you guys know that. And then, of course, you know, our heart is having to pump a certain amount. It's got to overcome peripheral vascular resistance, and that's the resistance to the flow of blood. And that's determined by the diameter of our blood vessels. So if our blood vessels are clamped down and they're constricted, then our heart has to pump harder to get through that tension, right? Because it's smaller than usual. Now, if our heart is pumping and our vessels are very dilated, then you know, our heart doesn't have to pump as hard. So I just wanted you guys to think about you know, how that works. Now, of course, I say this in every thing that I lecture about. You know, our body wants to maintain homeostasis, and so it's going to do that by whatever means that it needs to. So it uses all of these things at its beck and call to try to keep homeostasis there. You know, all the things that we talked about, all of the mechanisms that control our blood pressure, all of those things it is going to use to try to keep the blood pressure where it needs to be at a normal level. Now, I'm really not going to talk a whole lot about where everything is and what exactly it does, because that is a review. So you guys can look through that and just review. Now, I did put the formula in there that the blood pressure is the cardiac output times the peripheral vascular resistance. That's just, you know, in your book. Now, I do want to remind you guys about the ROS system. I want you guys, if you don't have that clear in your mind, just go back and look at that. You know, some people remember it and some people don't, but that's just the kidney's way to control blood pressure. So just go back and take a peek at that if you don't remember that. But anyway, you know, there are other things that affect the blood pressure. Of course, our emotions, if we're excited or we're in pain, if we're angry, of course, increased physical activity, hyperthermia, hypothermia, all of these things affect our blood pressure as well. So, you know, there are external factors as well as internal factors that affect our blood pressure. So anyway, I'm going to move on to the stages of hypertension. And like I said, I'm just going to let you guys look at those. But what I am going to say is that at any stage of hypertension, even at pre-hypertension, which, you know, that's our 120 to 139 over 80 to 89, you know, it's quite a range there. Your blood pressure may be 120 over 80. Now, what are we going to do? Are we going to just go, oh, that's pre-hypertension, or are we going to get another reading? I mean, anytime we're looking at somebody having a diagnosis of hypertension, we are going to get 2 readings, right? Of course, we want our patients sitting there with their legs flat on the ground. We don't want their legs crossed. We want them to come in at different times. So, we're not going to just check it and 5 minutes later recheck it. Of course, our blood pressure will more than likely be different in that next 5 minutes, but we need it on 2 separate visits. The patient may have almost gotten in a wreck, or they may have fallen in the parking lot, slipped on the ice. I've had that happen to me, obviously. That's why I come up with these things, is because usually it's happened to me. So anyway, those things will elevate the blood pressure. And of course, the white coat syndrome, things like that can definitely give you I hate to say a false reading on the blood pressure, but it's not a good indicator of the patient's all day, every day blood pressure. So, we definitely get 2 readings on separate visits, just so that we're sure it is hypertension or pre-hypertension. Now, this is where the whole really good blood pressures come into play. I have worked at a doctor's office once, and we used those blood pressure machines, not the kind that we have in the hospital, but the kind that you can pick up at Walmart, those kinds of things. I took my own blood pressure. I run low. I mean, half the time I'm, 60/40. I mean, that's a good for me. And it showed my blood pressure is 140/80 one day. And then we checked it manual, and it was 60/40. So it's really good to, and I'm not meaning that anybody's being lazy. That's not what I'm saying. But it is so important for people to get a good blood pressure and not just stick with that just because it's easier. They don't have time or whatever. We really need a good reading, because we don't want to start a patient on medication when they don't actually have hypertension. I personally don't want to pay for a medicine that I truly don't need, and B, all of the side effects and the risks, and do we have to check kidney functions? Does it mess with my liver? All of those things. So it's really important that that we have a true indication of the patient's blood pressure. So now the JNC7 report, I did stick a link in there for you guys. Now this is the report that I use. This is a condensed one. It's a 57-pager, and that's what I use as a nurse practitioner when I'm prescribing for patients. And that's not something that you have to look at. That's just one of those things that I put on there just in case you guys would like to see the full guidelines instead of just seeing just a snippet here. So I put that in there just in case you guys want to see it. And of course, that's obviously not something that you have to have right in front of you, but just for those of you, because I know some of you guys like to look at extra things. So now, as we increase in our blood pressures, of course, we're adding things to it. Now, anytime anybody comes in and we're worried about their blood pressure, the first thing we're going to do, we're going to get them in there and we are going to educate them on lifestyle changes, right? Because a lot of times these lifestyle changes can actually get their blood pressure down enough that they don't have to be started on medication. Now, diet is a big one, and exercise is a big one of the lifestyle modifications. Of course, stopping smoking. There's just a really long list, and I've got it in there as well. If we can get a patient, and typically this applies to them if they have diabetes as well. If we can get the patient down even 10 pounds, you wouldn't believe what it'll do to their blood pressure readings and what it'll do to their glucose readings. So hugely important for us, to make sure that, we're really pushing that. Now, I can tell you, most people do not want to do it, period. Here's the kicker. Most of the time, if patients have pre-hypertension or things like that, they don't feel bad. You get into stage 2 hypertension or stage 3. I mean, you get on up there, you have symptoms and you have problems from it. People don't want to do anything if they don't have problems for it. So that's the kicker, is that it's really hard to convince somebody that doesn't feel bad from something that they need to do something. So education is hugely important. Sorry, I've been talking too long. I may have to get me a drink. So anyway, what we're going to do as we go through our hypertension levels, we're going to start adding stuff. Everybody, it doesn't matter what stage they're in, we are still going to push those lifestyle modifications. It's just that we're going to add stuff to it as we go along. Medication will come at stage 1. And then, stage 2, we've usually got at least 2 medications. And the reason why we do that is we have to keep the organ damage down. I talked to you guys earlier about the target organ damage. In target organ damage is what it used to be known as, but now people just pretty much call it target organ damage. And I can't hardly say it all in one whack anyway. I get tongue twisted. But what we're trying to do is we're trying to save our heart, we're trying to save our eyes, we're trying to save our brain, and we're trying to save our kidneys. Because all of these things affect our major arteries, and all of our major arteries feed these really important things. Now, while we do have 2 kidneys and we do have eyes, 2 eyes, we've only got 1 brain and we've only got 1 heart, and we really don't want to mess up our vision or our kidneys either. So it's just better to take care of these things on the front end. And so that's where the education comes into play. Is sometimes you've got to do a lot of sweet talking. Sometimes you have to use scare tactics too. This will happen if you don't do this, this, and this. So just do what you can. Now, I have to say that there are certain populations that have a bigger issue with high blood pressure than others. Most of the time, African Americans have a bigger issue with hypertension. Well, with all of the cardiovascular diseases, they are affected 4 times more than any other group. So it's really, really important to stay on top of their blood pressures more. And we're looking for certain things more. Like, we're going to be looking for certain symptoms. If they're having chest pains, if they're having this, if they're having that, we need to be on top of things and make sure, because we know that they have such issues with blood pressure and atherosclerosis and all of these cardiovascular issues. So, we're going to be looking harder at certain groups over others. Now, essential hypertension, that is just a chronic high blood pressure that happens, and there's really no cause for it. This is, what most people have when we're talking about hypertension is essential hypertension, like 95% of people that have it. Now, some of it's genetic, some of it's environmental factors. Like I said, African Americans are at a higher risk. Now, the thing about it with the African Americans, now I told you that they have a higher incidence, but also it accelerates faster and they have a higher morbidity. So it is so key to keep a close eye on these blood pressures. Now, secondary hypertension, that is just because it's from a disorder. So if a patient's got kidney disease or something along those lines and they've got high blood pressure, then it could be that it's a secondary hypertension. So this hypertension, our cardiac output goes up, and or our peripheral vascular resistance goes up. Now the kidneys, what you guys remember what they normally do, right? And remember I told you guys to review your RAAS system or RAAS system. What they're doing, they're trying to help things out by excreting salt and water to lower the blood pressure. But if a patient has hypertension, they can't do this like a normal person. It just doesn't work. And especially while this pressure increases, this kidney damage is getting worse and worse and worse, and so the kidneys aren't able to function as well. So it's just kind of lose-lose for them. So that's the reason why we want to keep kidney function as long as we can and keep the blood pressure down. Now, when we're talking about a patient with hypertension, we're looking for signs and symptoms like nausea, vomiting, headache, dizziness, sleepiness, irritability, visual disturbances. Those are some things that we may see. Now, I also can't stress enough. Now, I'm going to tell you, I've been assessed myself many, many times, and I don't think that one person, except an eye doctor, has ever looked in my eye. You know, the eyes are the windows to our soul. Well, they're also the windows to our vascular system, and we can really catch some hypertension really early, you know, by looking at the retina. Now, you know, long-term hypertension, it causes all of these things. If we don't treat it, we don't diagnose it, we don't see it, people come in with these serious things like heart failure, stroke, um, a heart attack, things like that. So education and screening are hugely important. So every time you talk to a patient, you're going to be telling them the same things. You're going to drill it into their brains. They're going to hear this so many times, they're sick of hearing it. But if it gets into at least one person, and we can save at least one person, your education is worth it all. Now, we're doing the testing, right? We've got to test, and we've got to see. I mean, first of all, we want a baseline. And then we're going to be testing, and we're going to look at their status over time. So that way we can just monitor what's going on. Now, we're going to, of course, do our blood pressures. We're going to do our UAs because we're looking for protein in the urine, right? That's a big indicator. We're looking at our BUN and creatinine and the ratio because we're looking at how the kidney function's doing. The aldosterone, renin, glucose, sodium. There is, let me flip over to page 1061 while we're talking here. Come on, page turn. And it shows you a list of diagnostic tests. Big list there, and it's got you know, everything listed on there. I wanted you guys to be sure and see that that was there. Now, this is something that's important to know, and you will see this on test. The DASH diet, because, you know, we talked about what we're going to do for patients with high blood pressure. Diet and exercise. We want that weight down. We want to get that stress down. We want to limit our alcohol do you guys remember? Yep, it's is it 1 drink a day for women and 2 drinks a day for men, or do I have that backwards? That'd be something for you to look up and see which one it is. But medications, and then again, we've talked about you've got to consider their age, culture, blood pressure readings over time. We've got to be thinking about the drug costs. Do they have family and social support? Any coexisting diseases, and what kind of follow-up care they need. But let's get back to the diet. The DASH diet, you guys know that a heart-healthy diet, we're going low sodium, we're going low fat, low cholesterol. We want high potassium, high calcium. So we want our fruits, our vegetables, our, you know, all of those things. And we'll talk more about diet as we go. But I want you guys to know that you will see the DASH diet. You will see it on your boards for sure. You might see a test question about it even. So I want you guys to know about that. Now, exercise is one of the biggest things. You know, you can't just drop your calories down and eat healthier and not exercise. They kind of go hand in hand. Walking is a great thing to do. If you can exercise, just something that gets that heart rate up, 30 to 45 minutes for 30 to 45 minutes 3 to 5 times a week is a beautiful thing. It goes a long way. It will help a lot of things. If patients are having intermittent claudication, which we'll talk more about later, things like that, all of this will help build up and improve their cardiovascular status. So we really need our patients to do that. Also, we don't want to do any heavy lifting. You know, we try to stay away from that. Let's see here. That's really all I'm going to talk about right now. I don't want to go into medications right at this moment because we'll talk about those a little bit more. But as you guys know, this is not a one-man show. This is a lot of people working together to try to get blood pressures down. Now, I went ahead and put hypertensive emergencies in here. So if you do not treat high blood pressure, 90% of your patients are going to really possibly die from an MI, a stroke, an aortic dissection, or kidney failure. It's just, you're just playing with fire. Now, of course, a hypertensive crisis is a blood pressure that's greater than 240/130. So we need to get that blood pressure down within an hour, or we're going to lose some organs, right? And then this patient, if it's their kidneys, they may be on dialysis the rest of their lives, things like that. So really, really important to recognize early and get the patients in. So, when we're teaching our patients, we're not just teaching them, we're teaching their family, because if a patient is in severe distress like that, they're not going to go, wait a minute, I've been sick for 17 minutes now. I've got 10 minutes to get to the hospital so that they can do something within the hour. People are sick, so their families need to know what to do as well. And that's where our social issues come into play too, because if our patients don't have somebody there with them, we may have to come up with a different plan for them. They may need Life Alert, or if they're homeless, we may need, there's the social issues are endless. So it's really important to know those things so that we can help our patients. Now, peripheral arterial disease, I went ahead and put the American Heart Association's definition because that's a really good one. Vascular disease caused primarily by atherosclerosis and thromboembolic pathophysiological processes that alter the normal structure of the aorta, its visceral arterial branches, and arteries of the lower extremities. Now, that's a mouthful, but that, if you think about it piece by piece, it's a really good definition of what peripheral arterial disease is. Now, as you guys know, this is not something that just pops up one day. We start building plaques. Plaque has been found in the arteries of babies. Not every baby, but they don't go through and look at every baby. But you know what I'm saying. Plaque builds up from essentially birth. So this is something that builds up. So this is a chronic disease. This is a progressive disease. The problem is that it's underrecognized and underdiagnosed. And that's the problem here. A lot of patients, again, don't come to the doctor unless they have problems. Or when we're having our patients in for their yearly physical, we need to really be on top of our game and make sure that we're teaching them these things. Even if they don't have symptoms of it, we might do an ABI, ankle brachial index, on all of our patients as a yearly screening is a great thing to do. So, all of these things are things that they don't just pop up and go, oh, this is just an acute thing. This happens over time. So this is the reason why it's important for you guys to teach this over time. Now, remember that with all of these cardiovascular disorders, they don't happen in one spot. This is systemic. Most of the time, if somebody's got a clog in their leg, they got some plaque building up someplace else, and usually in the heart. So we need to really get a good history so that we know what other symptoms that these patients are experiencing. Now, atherosclerosis, as you guys know, that's a buildup of fatty substances. We got cholesterol, cellular waste products, calcium, fibrin. All of those build up in a plaque, and they cause the vessel lumen, the inside of the vessel, to be narrowed. So blood's not going through as good, right? If blood's not going through as well, does stuff hang on it? Does it catch on it? Does it stick to it? Yes. And it narrows and it narrows and it narrows until there ain't nothing going through it. And that is not a good thing. So, will we hear anything? Will we hear a bruit? Will we hear, what are we going to hear over these things? Those are things that you guys need to be thinking about. Now, peripheral arterial disease, that is atherosclerosis at different areas. Now, it can be anywhere along the aorta. You guys know the anatomy of it. The aorta bifurcates and it goes down, and we've got it going down into our legs. We've got the iliac arteries. We've got all these arteries that go through there, and it can be at any place along the aorta that these happen. Now, I'll just leave it at that. It can be along anywhere that this happens. Now, I think that's really all I'm going to talk about. Oh, but I did want to talk about, and I can't remember. I'll have to go back and look and see if I put a definition in there. But you guys already know what it is. But I try to put stuff in there just so that it jogs your memory. Now, we can throw a clot, and a thromboembolism is just what that is. It's a clot that will rupture if a plaque ruptures, and the clot can stay there a thrombus can stay there, or it can move to other spots in the body. So that's something that we're looking for as well when we're checking for patients. I mean, it can go through and it can clog, you know, down in the leg, or it can hit in the be a pulmonary embolism or things like that. So those are things to think about when we're talking to our patients and assessing them. Now, when we're talking about peripheral arterial disease, now I put on here a list of what you're going to see. Intermittent claudication, that is just simply exercise-induced leg pain. If we're not doing anything with our legs, they don't hurt. So it's just when our legs are moving, and it's not sweating to the oldies or anything. I mean, it could just be walking from a patient's chair to the bathroom. So that is the most common symptom of peripheral arterial disease. So that is something that you're going to hear from patients. And, they may describe it as an achy, a crampy, a tired, fatigued, sometimes it's hard for them to put their finger on. But what's happening with that is, you've got that narrowing, or stenosis, or you've got that complete blockage, which is also known as an occlusion. And does blood get through there? Well, if it's occluded, no, nothing gets through there. So we're going to have a blue foot eventually, aren't we? And we're going to have a lot of pain because that hurts really bad not to get oxygen to tissues. I don't know if you guys have ever been out in the cold and stayed out too long and your hands hurt so bad because there's no blood flowing through there, and it hurts terribly bad. And of course, if it's the stenosis or the narrowing, then some blood's getting through, but not enough. So patients experience pain. Now, I want you guys to think about this. When you are exercising or moving or just anything, our muscles, we got to have oxygen, right? Now, if we've got peripheral arterial disease, our muscles aren't getting what they need. So you guys have felt the burn. If you've exercised too hard or things like that, you get lactic acid, right? And that is just a byproduct of essentially your muscles are breaking down themselves because there ain't no oxygen in there to use for them to move. So you get that lactic acid buildup in there, and that causes a burning sensation. So when you stop, pain goes away. You're not requiring that oxygen anymore. You don't have that lactic acid buildup because you aren't doing anything. So that's kind of the bad part, is because patients want to stop when it hurts. But you've got to get them to stop smoking, and you've got to get them walking, because they will build up endurance through walking, and it can be 10 steps today and 50 steps for a week next week. I mean, you got to start off with baby steps, because these people don't feel good. They're not going to want to do that. But you got to start with baby steps. And as you progress, they may form some collateral circulation or things along those lines that help get oxygen to those tissues that they're working. So exercise is the key. Now, if patients have pain while they're resting, that's the ischemia part. Most of the time they have toe pain, foot pain. This will keep them up at night. They won't be able to go to sleep because it hurts so bad, or it'll wake them up. And that's how patients typically, they really have a hard time sleeping. A lot of patients that I've known with this really sleep in the recliner. Dangling their feet feels better. So I've seen patients actually sit up without clicking the legs up on their recliner just to sleep. So if you've got a patient that tells you, hey, I sleep in my recliner at night because I'm so uncomfortable, and they can't describe what they've got, you better be taking those socks off and looking at them and seeing, because we got to get a good assessment and a good history from our patients. Now, as you guys know, if you don't have blood going through, if you've got pressure, you've got trauma, all those things, you can get an ulceration, right? So you can have ulcerations from this. So we're watching for gangrene and infection. Now, peripheral arterial disease, it's 1/5 of all leg ulcers are caused from it. So it's not. I mean, still 20% is 20%. So we definitely need to be, looking at those things. And of course, what are we looking for when we're looking for infection? Or we're looking for our low-grade fever, warmth, redness, pain, edema, swelling, redness. We're looking for new or increased drainage, smelly odor. Now, If it's serious, we're going to go on to sepsis, right? And we, you know, that's going to be a big thing. We obviously don't want it to get to that point, but if it does, we're looking for um, patients confused. They may be, their respiratory rate may be up, their heart rate's going to be up, the fever, chills, their white count's going to be up, they're going to be tired, just exhausted because that infection is just spread throughout their body. So, since peripheral arterial disease, well, all the cardiovascular diseases pretty much are a lifelong disease, you always have to stay on top of things. So, I want you guys to be thinking about all the people that can help you. You're going to need dietitians to teach the patients what to eat, and you're going to need wound specialists to help with the dressing changes if they've got ulcers. So, we're going to use all of the resources that we can, but we can't forget the most important resource person that we've got, and that's the patient. If we don't have them complying with what we tell them to do, or what dietary tells them to do, or what OT or PT or whoever the physician, if we don't have patient compliance, we don't have squat. Because we can work on them all day long, but if they don't do anything at home, well, I mean, I guess even in the hospital, if they refuse to eat what we bring and eat a cheeseburger every day, but the patient has to be on board with this. So that's hugely important. Now, I did mention it a little while earlier, but here's my soapbox again. You have to take off patients' shoes and socks and do a good examination. I know that we talk about that in the diabetes lecture, but it's so key for these things too. You've got to get a good look at patients. If they've got ulcers too, we're going to be following those. It may be that, as they heal, we're going to be taking pictures of them to make sure that they're improving and going away and things like that. But we have to do a good exam, and we have to have good documentation. Now, I mentioned something about the ankle brachial index, and that's on page 1070 in your book. I just want you guys to look at that. If we've got an ABI greater than 1, that's normal. But as our numbers decrease, we've got a big problem. If it's below 9, we've got the actual diagnosis of peripheral arterial disease, and below 0.4, we've got severe ischemia. I mentioned some of the drugs here in the testing and treatment, and we'll talk a little bit more about that as we go. But I wanted you guys to think about some of the meds that you're going to be giving patients and what they're going to be taking. Now, we want those risk reductions down. Patient may require a repair of some sort. It may be endovascular, which is, that's from inside the vessel, like a stent, angioplasty, things like that. They may need a bypass, or, depending on where it's at, is what is the name of it. So I didn't go into all that, but I put page 1072 and 1073, and it shows good pictures. I'm going to flip over there. Because I thought it had a FemPop. Yep, it's got a picture of a FemPop and an iliac endarterectomy, and what else is that one up there? Aortoiliac bypass, and the anyway, it's got all those pictures in there. Sorry, I'm trying to look and get the page turned and all that good stuff. So just look at those. Now, stopping smoking is huge. We're going to be watching the hemoglobin A1C. Now, we definitely don't want heat trauma or sunburn on that area. And then we've got to keep that LDL below 100. So, now, aspirin stops platelets from aggregating or gathering up, right? So that's how it works to keep clots from forming. While I'm thinking about it, since we're talking about these procedures now, the PTA, or the percutaneous transluminal angioplasty, a lot of people over the years have called it Roto-Rooter. They've gotten out of that because you kids don't know what Roto-Rooters are these days. So all of us older people know exactly what people are talking about, but I'm sure a lot of you people don't. But anyway, that's what a lot of people have called it over the years. So that's something that's done. They usually numb the groin up, and then use some Versed to put the patient not really out, just a little bit more comfortable. Um, we do procedures like that because if we think it's going to improve their symptoms, then that's great. That's what we're doing it for, right? Now, what I want to tell you guys, that whether we're talking about an angioplasty, whether we're talking about a heart cath, any of those things, I want you guys, well, I guess really anybody that comes in with, this issue, always mark their pulses. I'm talking posterior tibialis. I'm talking dorsalis pedis. I want you to get in there with a pen or a Sharpie or whatever you've got. You may have to pull out a Doppler. It. I don't care how you got to do it, but I want you to mark everybody's pulses. That way, every time you go in, you can find their pulses. You'll know exactly where you found them to begin with, because most of the time these patients, if they've got a plaque down there, they don't have good circulation to begin with. So it's really key to know a baseline. And then after they have the procedure and we've got things restored, then we should have a better pulse. The appendage should be warmer, whether it's the foot or the leg or whatever. So I really want you guys to do that. If you get somebody back from a procedure at Cath Lab, don't leave their socks on. I know their feet are going to be cold. Stick an extra warm blanket on there. You need to uncover the feet and look at them when you're checking the pulses. I cannot stress that enough, just because if we don't have a pulse, that's an emergency. They are going to go straight to surgery if they do not have a pulse. So we have to be on top of these things, right? So anyway, there's my soapbox about that. But I just probably because I was, that's what I did for so many years, was recovering heart caths and all of those procedures that they do in the cath lab. I'm very particular about that, and so I want you guys to be particular about that, because it's a very serious thing. So we've got to conserve circulation, period. Now, smoking is the single most important factor in this, so you've always got to try to get your patients to stop smoking. Big thing. Now, lipid levels, if we get those lipid levels down, it's going to decrease their intermittent claudication, right? It's going to decrease their symptoms. So just really, really hugely important to get that down. Now, Raynaud's. I'm not going to talk a whole lot about that. I want you guys to just look over that. There's Raynaud's phenomenon. There's two types of Raynaud's, I guess I should say. So, most of the time you see people with the white or blue or red fingers is typically what most people think of when they think of Raynaud's. Of course, it's more common in women. It can happen in the toes and feet, and I personally have Raynaud's phenomenon in my feet more than I have it in my hands. So, it just depends. But you can do the ice water challenge. Not really fun for your patients, but that is a good way to see if the patient has Raynaud's. Thoracic outlet syndrome. This is one of those rare things, and it's just that there is not room for everything to fit. Whether it, most of the time that I've seen the thoracic outlet syndrome, and like I said, I haven't seen it many times, but it's been from a clavicular fracture. It hasn't been from an extra first rib. That's just one of those complications, and I'll let you guys look over that yourself. Now, the renovascular disease, I kind of lectured on that earlier. Atherosclerosis is the main cause of it in 70 to 90%. That is the culprit. So we don't get the blood flow to the kidney. So we get more renin being spit out, and then we get more angiotensin II spit out. So that's what happens then. Then we get vasoconstriction of the vessels. Then we get aldosterone levels coming up, and then we get sodium retention coming up, and then we get an increased blood pressure. So this is kind of that vicious cycle that you get in when you have kidney disease. It just causes more problems, and it's just a vicious cycle, and you have to break it someplace. So we definitely want to keep a good eye on our kidney function. That's pretty much all I'm going to talk about, because you guys can read. Aneurysms. You guys know that there are 3 different types, and I have on the next slide, I've got a picture of that so that you guys can see the different types. I'm always a visual person, so I always try to get those in there. So what happens is the artery is diseased. It gets thin and it pouches out. It's kind of like, well, it can happen in lots of places. I talked about it in the GI lecture. That's essentially what happens. It's just that outpouching. And so anyway, what you're going to hear is you're going to hear a bruit, and remember we talked about the turbulence in the vessel. It's not smoke. I'm so tongue twisted. The blood cannot flow through there smoothly like it's supposed to, so it gets turbulence, and you're going to hear that bruit. Also, with this, you're going to feel it. It's a pulsatile mass. It pulsates. You're going to feel the heartbeat in that mass, in that aneurysm, because that's what's happening. The artery can't. I'm not even going to go there. I'll get you guys confused if I start talking about the mechanics of it. But anyway, I want you guys to read over this. What we worry about is rupture, right? Now, aneurysms just grow. They're going to start off small, and they're going to get bigger and bigger and bigger as our blood pressure goes up, as our vessel gets weaker and weaker, because trying to handle all of this stress, it's going to get bigger and it's going to get thinner, and then we've got to worry about it rupturing. So what are we looking for? Patient is restless. They may have abdominal pain and tenderness. They may have hypotension. They may have shock. All of these things, if they've got abdominal or back pain, you better watch out, because they are fixing to blow or are blowing, or it's a bad deal. So just really have to watch out. Now, usually with these patients, we're going to be doing, let me start off by saying, usually what we're doing is an abdominal ultrasound every 6 months. Now, as it gets bigger, we may have to do that more frequently, right? Because it gets more serious. So the bigger it gets, the more that we may have to start doing about it. It's not really called a AAA until it's 3 centimeters or bigger. But the biggest thing that we can do is stop smoking. Biggest thing that we can do is have our patients, not us personally, but our patients stop smoking. That sounds better. We've got to get that blood pressure down. We've got to get those lipid levels down. If the patients are on steroids, if we can, we need to get them off of those. But they may need a stent. They may need surgical repair. Now, I want you guys to know that if they have a family history of an aneurysm rupture, you better watch out, because that typically will be the case with your patient. So you know, if they've got a family history too, you need to be asking that. And I didn't stick that in the slide, but that's something that I want you guys to know. Now, once the aneurysm reaches about 5.5 centimeters, and of course that's up to each physician, each surgeon, I guess I should say, and physician, is when they're going to start doing something about it. Now, used to, this was a huge surgery until we came up with these stents and things. And, you know, if we can get them in earlier, not later, then, you know, we can usually save the big AAA repair. So anytime they have a surgery like this, we've got to worry about, you know, we've got to worry about infection. We've got to worry about, you know, rupture. We've got to worry about, there's so many things. I think I said rupture. So bleeding, MI, hypoxia, fluid and electrolyte imbalances. A lot of times they can have some GI stuff because of the bowel has to be moved out. Well, you have to pull all of the bowel out to get to it, right? Because your intestines sit on top of it, of your aorta. So everything has to be moved out of the way. So sometimes it can get nicked, or a clamp hit it, or, you know, all of those kinds of things. And then also the clamping that you do, because, you know, obviously you have to clamp it on each side to repair it. It can also damage the spinal cord as well. So those are all things that we worry about. So, you know, if we've got a patient that comes in and that's what we're thinking, oh, geez, we better get that IV going because they're going to need some serious IV fluids and blood, and we better be getting that blood pressure down, right? So all of those things are things to think about when we're talking about these patients. Now, they're going to be in the ICU for a while. It depends on the procedure that they have. If it's a really serious surgery, they may be in there for a few days. But these days, the ICU stay isn't what it used to be. But we're obviously watching for any bleeding. We're watching their volume status. We're making sure that they don't have an MI. We're keeping that blood pressure down. We're worried about hypothermia. We're doing their pulses, neuros, all of these things that we're doing. Now, we've got to educate our patient before surgery, right? I know that some of you guys have had SimLab. I don't know if everybody's SimLab is the same, but I know in mine I had the students do incentive spirometry, and I made them do it themselves so that they could see how challenging it is. If you know how something is and how it feels and all of those things, then it's a lot easier to teach your patients about it. So we're going to teach them about all these things before they have the surgery, because obviously they're going to be loopy afterwards. So, their wounds, what their wounds may be like, wound care, what their restrictions are. You can't be lifting more than 3 to 5 pounds for a certain amount of time. That's going to be a big one because they can't lift. You don't want them going to the grocery store and carrying 3 gallons of milk all in one whack the week after surgery. Not a good idea. So those are things that we're going to be teaching our patient beforehand. Of course, smoking is a huge one, and we've got to teach them about diet as well because we want those lipid levels down. Now, remember we talked about some of the GI issues. When they put the graft in, it can rub on the duodenum and it can cause a GI bleed. So they need to know about GI bleeds. And also, if they throw a clot, we need to tell them the sensations that they may feel if they have a clot, like, pain. And you might even want to teach them how to feel their pulses and see if they can feel it, or if your foot gets cold or things like that. Those are all things that you're going to be teaching your patient beforehand. Now, an aortic dissection is a life-threatening thing, and so what happens is the tunica intima, which is the inner lining of the vessel, right? Blood will flow through there and go into the tunica media, which is the muscle layer, right? It's the middle layer. So what happens is blood flow distally is not happening. Now, typically this occurs between the age of 40 and 60, and 2/3 of it's in the ascending aorta. Now, I did put the risks on there. Now, as you guys see Marfan syndrome, and I know that you guys know what that is already, and if they've had surgery and they had their aorta clamped, we've got to worry about an aortic dissection. So see, that's going to be a post-op complication of an aortic aneurysm repair, right? Now, this catheter-based interventions, if they have a procedure, then that obviously can cause an aortic dissection, because that goes through the inside of the vessel, so that can cause trauma, which can cause this dissection. Of course, high blood pressure, and then a degeneration of the tunica media. So it's much the same. We're going to be doing the same thing. It is an emergency, so you've got to recognize it quickly because we don't want our patients to be harmed. I put a picture up there of the 3 in there for you guys so that you can look at it. And now we're going to move on to venous disorders. And of course, this affects the lower extremities more than their arterial disorders. So you're going to see lots of different symptoms. Patient may complain of discomfort or tightness, intermittent swelling. Now, when we're talking about varicose veins, those valves are not working right, and so we have some reflux in there, and so the veins get tortuous and they get dilated, and we get those ugly varicose veins, which aren't very pretty. So obviously you can look at them and tell what they are. You can do a Doppler ultrasound as well. Now, there are different treatments. Sclerotherapy, which is injecting a solution in there. Most of the time, if you go to your doctor, they will take just a small tuberculin needle and just some plain old normal saline, and they can inject it into the smaller ones. Spider veins especially works really good for, and that is sclerotherapy, and it will help decrease those. They can do a vein ligation or a vein stripping, or just an ablation for treatment. Now, a venous thromboembolism. We're talking our DVTs, our PEs. They cause over 200,000 deaths in the U.S. every year. Now, I want you guys to look at page 1083 and page 1084, and you're going to see some more information on those. So just look over those. Now, of course, DVTs, anytime we have venous stasis, so if a patient's immobile, if they're on bed rest or they've had surgery and they've been in bed for a long time or things like that, those are things that will contribute to a clot forming. Now, a pulmonary embolism, that, which is really painful, shortness of breath, we see all of those things, but that gas exchange can't go on if we've got that vessel occluded. So anyway, I think that's really all I'm going to talk about, because everything is on there. I'm trying to get over. There's the other slide. Yeah, I went ahead and put a visual in there for you guys to show you how blood is moved through the muscles. Because sometimes it's hard. I may say that and you may not see it. So that's just a good visual for you guys. Now, anytime we have venous disorders, that's something that it's going to go along the same as with the arterial. We don't want them smoking. We want to control the blood pressure. Now, I want you guys to think about it as far as risk factors. Pregnancy is a big one that most people don't think about. A lot of people do develop a lot of varicose veins and DVTs when they're pregnant. If you guys read anything about, I may have to pause this for a minute and get a drink because my voice is about gone. Your estrogen levels can affect that. So I think that I've got that later on in a lecture, and I'll try to talk about it more then. But I didn't want to just really overwhelm you guys with too much information. But yes, pregnancy is a big one, and then a patient that is obese, they have a lot of issues with their veins as well. Let's see here. I think that I want you guys to know about sclerotherapy for test purposes, but I can't. I'm pretty sure. I'll go back and look at that, but definitely look up sclerotherapy. And I talked about it a minute ago, but I think that that's gonna you're probably going to see that later. But like I said, when they inject that solution, it causes the vein to scar and collapse, and so blood flow will just go into the healthier veins. Is how that works. Weight loss is key. We talked about walking. Compression stockings is a big one, and I always tell anybody that I've ever had as far as nursing students, always wear those. I know they're A, not pretty, B, not comfortable, but they will save you a lot of trouble as you're older. And I knew it, but I didn't do it myself. And I mean, mine aren't horrible, but I'm sure they will be by the time I get old. So be sure and wear your support hose or compression stockings. They've got them up to the knee. They've got them all the way up to the legs and all that stuff. All the way up to the legs, sorry. All the way up to the thighs. So just, that just helps the blood get back to where it needs to be. So really, really a good thing to wear. Now, also, I went ahead and I'm trying to get over to the page. 1082. 1083 has risk factors for venous thromboembolisms, so that you guys can look at that. I thought that was a good visual. And then also on the next page on 1084, it's got some guidelines and some evidence-based practice for prophylaxis for VTE. So I want you guys to look at that, because that's really good for you guys to see and think about that. So I really want you guys to read those if y'all don't care. Now, I also wanted to talk about a DVT. Back in the day, the first thing that we did was, yes, we're looking for redness, pain, swelling, warmth, tenderness, all of those things. But we do a Homan sign, and if the Homan sign was positive, oh gosh, they've got a clot in there. Well, do not use the Homan sign anymore. It's not reliable, and it's not evidence-based practice. So I really don't want you guys using that as something to go off of these days. And so I wanted to mention that. Now, I also wanted to talk to you guys about a couple more things, just because it's a safety issue for your patients. Now, if you've got a patient that's got a DVT, I guess with the pulmonary embolism as well, they're going to be on medicine, right? We're going to have them on a heparin, and then we'll start them on warfarin and or Coumadin, and maybe some Lovenox. Those three things. Those are things that we're going to do. Now, used to we'd keep them in bed too. Now patients can get up and walk as they feel like it. But we do want to, when we've got them in bed, we do want the extremity being elevated 10 to 20 degrees above the heart. Moist heat is always a good thing. Now, do not massage. We do not want to massage, because if we massage, what do our muscles do? They massage the blood along the vessel, right? So if we're massaging their leg, we're going to be pushing that clot up, and it may break loose and go to the lung or someplace, and we don't want it there. So do not massage. I just cannot stress that enough. And then, like we talked about earlier, compression. It may be the stockings, or it may be just those intermittent compression scuds, SCDs that they use at the hospital. It may be something along those lines as well. So those are some choices. We used to just have the TED hose, and that was it. So now we've got these lovely other things that we can use, and they're great. Now, our goal, we want to keep our patient's INR between 2 and 3. A patient comes in, we're going to start them on heparin. Now, if you see a patient that's on heparin and warfarin or Coumadin at the same time, do you freak out? Well, no, you don't, because the patient's going to be discharged, and it takes a good 4 or 5 days to get the blood level of warfarin built up in the blood. So if you see an order and they're on both at the same time, look at the dates and things, and it may just be that the patient's going to be discharged. I've seen so many patients go, oh my gosh, they're on both of these. It's okay. They're going to be going home on that warfarin, right? And they're going to be on it for at least 3 months, most of the time 6 months. Now, these drugs, are they clot dissolvers? No, they are not. They keep the clot that they have from getting bigger and new ones from forming. Now, I do want you guys to remember that if you give somebody heparin and you get their blood too thin, and you're like, oh my gosh, I've got their blood too thin, they're bleeding out from their every orifice. Not that they really will, or not that they really are, but they can if it gets if it gets their blood too thin, that you can give protamine sulfate, and that will counteract the heparin. If their warfarin has their blood too thin, what do we give them? Vitamin K, yes. It's always good to know antidotes of drugs, because if you're giving them, and God forbid they take 5 in a day and they're only supposed to take 1, stuff happens. You need to know an antidote to it, and they need to have it on hand. Now, these days, we stick those IVC filters in, the vena cava filters. Those things are great for catching clots and keeping them from getting to the lungs. Because, sometimes you can just be pooping, or just hop up from the chair, and that clot will go, and it will go straight to the lung, and it is not a fun thing. I'll tell you a story. My father-in-law, several years ago, he had a heart attack, and he was in the hospital at, this was back in 1982, and he was in the hospital at Baptist at Little Rock, and he was in the hospital for like 6 weeks. Well, he gets to go home, and he comes back in, 2 weeks, and he said he's having the most horrific heart attack on the planet. He's never had pain such, he still talks about that pain was the worst pain he has ever had in his entire life. Well, he threw a clot. He had a PE. So some people don't notice anything. Some people I've seen people that come in with just a little bit of shortness of breath, and we're like, oh, hey, Houston, after we do some testing on them. So some people don't really have a lot of symptoms, but most people have a really, really serious pain and shortness of breath with a PE. So, just want you guys to think about that. So we're looking for cough, shortness of breath. The breathing rate is increased. We're looking for a low blood pressure. Some well, like I said, everybody's different, but it may be a chest pain that's like a pleuritic pain. They may be wheezing. They may be passed out. They may go into cardiac arrest or circulatory collapse. Mortality rate is 30%, and most people die within the first hour of symptoms. So it's really important to stay on top of this and let our patients know what they're looking for as a complication. So, anyway, I just want you guys to think about that. I also want to talk to you guys about chronic venous insufficiency. There are a lot of symptoms that you see: swelling, pain. Usually you see that brownish, I know that you guys have all seen it, that brownish lower leg, that discoloration. Some patients have swelling as well. Dermatitis, ulceration, scarring. It may be from healed ulcerations, but it's just not a pretty sight. Most of the time they're having that crampiness and aching, and it just feels heavy. Now you can stick Una boots on these patients and do different things, and I stuck a YouTube video on there for you guys to see, just in case you guys want to see that. But like I said, we're going to be taking pictures because we want to follow that wound progression as it heals, right? No crossing of legs. Now if we've got a patient on anticoagulants, I went ahead and stuck a list on here. I give you guys the same lecture all the time. If we've got somebody that is on an anticoagulant, their blood is thin. So do we want them brushing their toothbrush with a corn cob? No, they're going to bleed. So these are just a list of things that I stuck on there. Now, remember we talked about Coumadin earlier, and we've talked about that vitamin K. Now, what does it do? Vitamin K stops the Coumadin from working. It keeps the blood from thinning out. So I stuck a list on here. Liver, asparagus, broccoli, Brussels sprouts, cabbage, cauliflower, lettuce. All of these things have a lot of, they have a lot of vitamin K in them. So if we're eating a salad 3 times a day while we're taking Coumadin, do you think it is going to work? No, it's not. Also, if they're taking vitamin E, it makes it work more. So it may make the Coumadin to thin the blood out more than it normally would. So their doctor needs to know that. And alcohol also messes with Coumadin too. So those are all things that the physician needs to know, because we want to be safe and make sure we're caring for the patient. So I've got signs of bleeding on the next slide. I put a slide in about arterial versus venous insufficiency, just for you guys, so you'd have a good visual on that. And then the last thing we're going to talk about is lymphedema. Now, lymphangitis, usually you got a strep infection there. It gets in and gets into the lymph system. I'm not really going to talk about that as much as I'm going to talk about the lymphedema. And we talked about that earlier. It's just an overload of fluid that builds up there, and it can progress and cause damage that is irreversible. So it's really important to try to get the lymphedema down as much as we can, whether it be from a lot of people have massage techniques and things like that, and I think that I stuck a video. Yeah, I did. I've got a picture of lymphedema, and I've got a couple of videos, YouTube videos, that shows you how to wrap those, so that you guys know. Not that you're necessarily going to be doing it, but it's really important to see how that works. So if you would like to check that out, check that out. Now, lymphedema, we diagnose it by a good history and physical exam. So we're asking all of these different questions. What surgeries have you had? Have you had radiation? Because that's a big one. History of radiation is a big one. Any trauma or infection, those are all things we're going to ask. So what we've got to do, we've got to keep the fluid from accumulating, right? We want that skin integrity. Once it gets so big, we've got huge issues. So we definitely want some compression on there. So like I said, I want you guys to look at that. This is a very frustrating thing. I don't know if you've ever known anybody that's got lymphedema, but it is I mean, we talk about turtle here. It is a slow process trying to get all of this lymphedema down. Some people never get it down, but that's why it's so important to try, because it is very, very frustrating. And there's a lot of complications. Who wants to have cellulitis? Who wants loss of function? Who wants a DVT? And who wants to be embarrassed? Because, these patients, it's very visible that their right arm is 10 times as big as their left arm, and they've got all these dressings on it. So it can be very, besides the pain, it's very, people don't want to go out. They're embarrassed. So, good skincare is the best thing that you can do. We want a mild soap. We want moisturizer. We've got to keep that skin moisturized. We don't want it busting open as it's stretching. So patients need to know the signs and symptoms of infection, because we don't want them getting an infection, and they need to be cared for quickly. I stuck a slide about gerontological considerations on there, because as you guys know, everything changes and slows down and is not as elastic and all of those things as we age. So all of these things changes our, an older person's quality of life. So they still have a life. We don't want them restricted by all of these issues. So, we want to get the risk factors down. So education is really key. But we don't want, obviously we don't want them to die prematurely if we can keep from it, but the disability as well. We don't want somebody that has to lay in bed all the time that was normally a up and functioning, live life to the fullest kind of person. So anyway, all of those things we have to take into consideration. And I stuck a list of things on this slide so that you guys can see what happens as we age. Now, another thing, older adults need to exercise. Low intensity workouts are great for them. Just because you're 70 doesn't mean that you don't need to do anything. You've got to keep going and keep exercising. So exercise is just as important as you age. You're just going to be, you're not going to go and lift, 150 pounds. You're not going to lift 40-pound barbells at the same time. We can't be ridiculous with it, but they still need to exercise and keep the heart rate up and all these things, because they still have all of these issues, and we still have to control all of these issues. We just won't do it like, we're not going to have them exercise like they were when they were 20. We still want the smoking to stop. We still want the blood sugar levels to be low, and we still want their blood pressures to be low. Those are all goals, no matter how old we are. But we do have to think about all of these things affect their brain as well. So we're going to be doing a good assessment of the cerebrovascular system as well. As I said, if you've got a clog or a narrowing or a whatever in your leg, more likely you got it someplace else, and it can be in your heart, or it can be in your brain, or it can be wherever. So those are things that we're going to be looking for. Now, I want you guys to think about as we age. Pneumonia is a huge thing. We got to worry about wound infections, atelectasis, all these things. So we're going to be making sure that we're doing good cough, deep breathing, ambulating. We want them eating properly so that they heal. So, and we definitely want to keep up our good technique when we're changing their dressings, because their immune response, remember, is crap. As they get older, it goes to pits. So all of these things are things that I want you guys to think about when we think about our elderly patients. That's it for this one. Thanks, guys.